In part 1, we looked at the cervical plexus. In part 2, we looked at the brachial plexus and its plexopathies. Now, in part 3, we're going to look at the lumbosacral plexus, its anatomy, and plexopathies. Here's a brief review of the lumbosacral plexus. Note that the plexus is derived from the anterior, i.e. the ventral rami, of L1 through the S4 nerve roots. The anterior rami, in turn, divide into an anterior and posterior divisions that in turn yield the individual peripheral nerves. The lumbar plexus is defined as being those nerve roots from L1 through the L4 area. They divide into an anterior and posterior branches within the body of the psoas major muscle. The posterior branches of this split from L2 to L4 become the femoral nerve. The anterior branches become the obturator nerve. Look at the names of the individual nerves in this tangle. The iliohypogastric nerve, the ilioinguinal nerve, the genitofemoral nerve, superior and inferior gluteal nerves, the lateral cutaneous nerve of the thigh, the femoral nerve, the intermediate cutaneous nerve of the thigh, the sciatic nerve. All of these you've heard of. And looking even more lateral, we have the pudendal nerve. And continuing with those nerves that you're aware of, the pudendal nerve, the perineal nerve, the genital branch of the genitofemoral nerve, the obturator nerve, the femoral branch of the genitofemoral nerve, the medial cutaneous nerve of the thigh, and the posterior cutaneous nerve of the thigh. Of course, we know the sciatic nerve, which I mentioned previously, is made up of branches from the common peroneal nerve and the tibial nerve. The first question you most likely have is, do I need to memorize the lumbosacral plexus with the same degree of detail that I did for the cervical plexus and the brachial plexus? Well, no, not really, but some of these branches are more important clinically than some of the others. For example, to the general surgeon who performs either an open or a laparoscopic hernia repair, the ilioinguinal nerve becomes very important, as does, of course, the genitofemoral nerve with its associated femoral and genital branches. And you remember from previous lectures learning about meralgia paresthetica, irritation of the lateral femoral cutaneous nerve of the thigh. These are important branches. So to prepare yourself for the upcoming slides, it might be a good idea to download this document which I've placed here, which is a brief review of lumbosacral plexus syndromes. Remember to take the PowerPoint out of presenter mode and download it that way. Thankfully, plexopathies of the lumbosacral plexus are relatively rare. That is, in comparison to other single peripheral nerve disorders. There's a wide array of causes of these plexopathies, and they most often present asymmetrically with focal weakness, numbness, and dysesthesias or paresthesias in multiple continuous lumbosacral nerve root distributions. In other words, they're not well defined. Perhaps the most common of these peripheral plexopathies is a lumbar radiculopathy known as sciatica. If you recall, the sciatic nerve usually goes below the piriformis muscle, but in up to 17% of the cases, it actually can go over the piriformis muscle. Nevertheless, it's these nerve roots from the sciatic nerve, L4 to S3, which become irritated, made worse by pressure, obesity, abnormal gait, etc. Other causes of a lumbar radiculopathy include the piriformis syndrome, i.e. Wallet sciatica, pregnancy, and of course tumors, i.e. the cauda equina syndrome. This carries a poor prognosis. If we can limit our discussion for just a moment to plexopathies involving just the lumbar plexus, we learn that the lumbar plexus lesions will tend to cause weakness of hip flexion and adduction, that's adduction, and or knee extension. Furthermore, as a generalization, sensory disturbance involving the anterior and medial thigh and the medial leg typically represents lumbar plexus involvement. So let's make some generalizations about sacral involvement in lumbosacral plexopathies. The lumbosacral trunk and upper sacral lesions can result in drop foot or what's called flail foot. depending on the extent of the involvement, and associated weakness of knee flexion or hip abduction, that's abduction. As a generalization, sensory disturbances involving the leg, the dorsum of the foot, the posterior thigh, and the perineum suggest sacral plexus lesions or lesions of the lumbosacral trunk area. I've placed some video links here that you can click on that'll take you out to the internet and demonstrate two tests which are used to evaluate for lesions of the lumbosacral plexus. The Faber test, also known as the Patrick test, the hip is externally rotated with the same side knee flexed at 90 degrees and placed on the opposite knee. The test is positive if it causes hip or buttock pain. Suspicions for hip or sacroiliac disease are implied by a positive test. This is nonspecific, however, for radiculopathy or plexopathy. A straight leg test is something that's often performed in the orthopedic clinic. The examiner raises the patient's extended leg on the symptomatic side with the foot dorsiflexed. Being careful, the patient is not actively helping to lift the leg. This is easier said than done. It's helpful for the diagnosis of a radiculopathy due to a disc herniation, particularly at the L5-S1 levels. As a general rule, MRI imaging is better than CT scan imaging to evaluate for lesions of the lumbosacral plexus. What are some other diagnostic tests used to evaluate a lumbosacral plexopathy or a radiculopathy? At the bottom of this page, there's a link to EMG, electromyogram studies. During an EMG, this can help distinguish between a lumbosacral plexopathy versus a radiculopathy. If the upper limb is also involved in an EMG, then these symptoms may be polyneuropathy, and this can be more of a systemic disease. An upper limb EMG may be necessary to exclude this. Nerve conduction studies also performed at the time of the EMG with abnormal motor but intact sensory responses of the lower limb, along with EMG findings in a myotomal distribution, that is along a specific muscular innervated range, with paraspinal muscle involvement, suggest a radicular process rather than a plexopathy of the lumbosacral plexus. At this point, we've mentioned imaging with MRI as being superior to CT and the importance of differentiating whether we have a sensory distribution or whether a myotome is involved rather than the dermatome. But now, what kind of lab test are we going to do to help us further our diagnosis, whether the patient's suffering from a very limited plexopathy or from a systemic disease? Well, first, we'll do a complete blood count with a coag profile. This can help tell us whether the patient's anemic, whether they have an elevated white count, which of course would lead us to look at an ESR and a C-reactive protein, looking for inflammatory sources. A glycosylated hemoglobin would also help us to determine whether the patient may be suffering from diabetes, and if so, how bad their diabetes is. Anti-nuclear antigens and anti-neutrophilic cytoplasmic antibodies can help us try to determine and rule out an autoimmune process. These other studies, for example, testing for an angiotensin converting enzyme or using serum protein electrophoresis, can all help us look for other more obtuse causes for a lumbosacral plexopathy. Serologies for HIV, Lyme disease, syphilis, etc., as well as a lumbar puncture might be necessary if our blood tests are negative. All of these tests can help us determine the cause of the radiculopathy or the plexopathy. If our physical exam, MR imaging, and blood work is not enough to help us in our diagnosis, we may need to consider a fascicular biopsy of proximal nerves and or the nerve roots and or a biopsy of skeletal muscle tissue. These two links here show you how those procedures can be done. Two of these three should come as no surprise: diabetes and or cancer as a cause of a plexopathy or radiculopathy. The first, idiopathic lumbosacral radiculoplexus neuropathy, I've never seen, and I doubt that you'd need to commit that to memory. It's similar to a diabetic amyotrophy. Diabetic amyotrophy usually occurs in type 2 diabetes. It's not a pure plexopathy because it also affects the lumbosacral nerve roots, and the peripheral nerves. The traditional features include an acute, asymmetric, focal onset of pain, followed by weakness involving the proximal leg with associated autonomic failure and weight loss. Of course, when cancer involves or invades the lumbosacral plexus, we can have a radiculopathy, a plexopathy, or loss of the peripheral nerve, direct extension of the cancer, spread to the meninges, secondary extension of tumor to the sacrum, to the iliac wings, and the lumbar vertebra can happen, and hematogenous or lymphatic spread of cells from primary tumor sites. A paraneoplastic phenomenon is seen on physical exam. An example of a tumor which spreading in the posterior sacrum and iliac wings and the lumbar vertebra would be prostate cancer. Some of these patients do present with neoplastic invasion of the lumbosacral plexus. No, of course, you don't need to memorize this list, but you should peruse it to get an idea of the causes of lumbosacral plexopathy. Many of these we've already touched on. For example, diabetic amyotrophy, the idiopathic etiologies, primary neoplastic invasion, metastatic cancer, some benign neoplasms, especially benign neoplasms of the bony lumbosacral spine area. Radiation is implicated again, as is ischemia. Postoperative changes, bleeding in the retroperitoneum, an arterial aneurysm or even a pseudoaneurysm, trauma, etc. You get the idea. Same thing here, goes without saying that most carcinomas can invade and involve any of the plexuses, from the cervical plexus to the brachial plexus, which we've already seen, now to the lumbosacral plexus, especially the male and gynecological disorders such as cervical cancer, ovarian cancer, vaginal and uterine cancer, as well as melanoma. However, we also have some benign etiologies which can cause invasion of the lumbosacral plexus, causing a plexopathy. A sacral chordoma, a sarcoma, which can be malignant, schwannoma, which is a tumor of the Schwann cells around the peripheral sheath of our nerves, uterine fibroids, neurofibromas, and other lesions. You don't need to memorize these. The ones to remember, of course, would be breast, colon cancer, lung, lymphoma, and the gynecological and male disorders, such as prostate cancer and the cervical, ovarian, and uterine cancers. So what exactly are we looking for on our physical exam for a patient who may present with a radiculopathy, a neuropathy, or a lumbosacral plexopathy? Leg weakness occurs in 86% of cases, as does sensory loss. Asymmetry is also an important finding. Up to 64% of patients will have reflex asymmetry. Tenderness in the sciatic notch or tenderness of the lumbar and sacral spine area. Positive straight leg raises, edema of the lower extremities, cancers in the rectum, dysthesias, and decreased sphincter tone, as well as fasciculations. We know from neuroscience that our fasciculations are most likely a clinical sign of a peripheral nerve involvement. Of course, if the physical exam findings are consistent with metastatic malignancy, the prognosis is very poor. The median survival from the time of diagnosis is only 6 months. We've mentioned how radiation can affect the cervical and or the brachial plexus, most commonly after patients are diagnosed with either lung or breast cancer. But radiation plexopathy can also be seen in the lumbosacral plexus. It can occur months, years, or even decades after pelvic irradiation has been given for a malignancy. It has a predilection for the upper plexus and is often bilateral. It is uncommon with external beam radiation. What does that mean? Most radiation today is external beam electron radiation. Radiation plexopathy, however, is more common with intracavitary radiation and intraoperative radiation placement of seeds, something we call brachytherapy. The cause, of course, is direct toxicity to the nerve itself, killing of the axons, microinfarction of the nerve axons due to radiation effects on the vasa nivorum, i.e. the blood supply to the outer aspect of the nerve cell, and of course from tissue fibrosis secondary to the inflammation from the radiation itself. How do we make the diagnosis of radiation plexopathy? Well, first, your patient would have a history of having received either external beam electron radiation or intracavitary radiation, i.e. brachytherapy. There's no known therapy, no effective therapy, and drugs based on neurotransmitters like GABA, such as Neurontin and Lyrica, are often used to treat a radiation plexopathy, but they're not entirely helpful, along with some of the antidepressants listed here. Myochymia by electromyography can help distinguish radiation plexopathy from recurrent tumor invasion. If a patient has recurrent tumor, they won't be able to have or show us myochymia by EMG. The picture here is to give us an example of what myochymia is in a normal patient. Sometimes your eyelid just quivers. You don't know why that is. It shows up on EMG as multiple fasciculations. That's what myochymia is. Trauma as a cause of lumbosacral plexopathy is unfortunately more common. This can be a result of a posterior hip dislocation, which occurs when the driver's knees hit the dashboard, causing the femoral heads to be impacted into the pelvic bones. A high velocity flexion abduction of the hip, and of course, hyperextension of the thigh with external rotation of the fractured or dislocated portion of the pelvis can also disrupt the plexus. Sacral fractures, pelvic fractures, open book pelvic fractures, which can cause intense bleeding. If the patient survives an open book pelvic fracture and doesn't bleed to death, they may have suffered a ripping or a shearing injury of this lumbosacral plexus. Management, sometimes nothing, sometimes nerve grafting. Either way, the outcome is poor. Another cause of lumbosacral plexopathy is pregnancy. Peripartum plexopathy, i.e. intrapartum or postpartum, are the most common. Antepartum plexopathies are rare. These occur because of the susceptibility of the pelvic brim lying close to the lumbosacral plexus during pregnancy. As such, injury near the pelvic brim is most common. Most of the time, this is only temporary and not permanent. Patients present with numbness or paresthesias of the lateral foreleg and dorsum of the foot. Foot drop can develop because of involvement of the lumbosacral trunk, and there can be weakness with hip flexion, hip abduction, knee flexion, and knee extension. Of course, if the patient's had an epidural anesthesia, these areas of weakness can be missed, and the obstetrician must be alert to it in the postpartum phase to make sure that such an injury to the lumbosacral plexus has not occurred. We've already mentioned vascular causes as an etiology for a lumbosacral plexopathy. A retroperitoneal hematoma after surgery on the femoral artery or femoral vein as a result of catheterizations, patients who are anticoagulated, and a postoperative complication such as a pseudoaneurysm or an aneurysm compressing directly on the lumbosacral plexus all need to be considered. Anything that decreases blood supply or stops blood supply to the nerves itself can also result in a plexopathy. Here's an image of a retroperitoneal hematoma compressing the patient's left trunks of the lumbosacral plexus. Another cause of lumbosacral plexopathy can be an aneurysm or a pseudoaneurysm. In this case, the aneurysm is labeled AN, and the clot from the aneurysm body itself is located by the various small arrows. You can see how this can compress on the posterior line lumbosacral plexus. We've already mentioned how infection can be a cause of a lumbosacral plexopathy, and sometimes we have to check for it in our blood work, and if that comes back negative, as we mentioned earlier, a lumbar puncture might need to be performed. Here we see that HIV, Epstein-Barr virus, cytomegalovirus, tuberculosis, even syphilis can cause the lumbosacral plexopathy. Inflammatory processes such as sarcoid, Sjögren's syndrome, lupus, these collagen vascular diseases and autoimmune diseases also need to be thought of. And of course, infiltrative etiologies like the pseudoaneurysm, and pseudoaneurysms can be caused from infection too, as well as infiltrative processes from neoplasms. This completes the third of 3 series in this discussion on the plexopathies, the cervical plexopathies, plexopathies of the brachial plexus, and of course, disease of the lumbosacral plexuses. Part 4 is only a collection of anatomical illustrations which I provided to help you draw and learn the anatomy of the various plexuses. Thanks for listening.